Hello, this is Dr. Mikey Blaya. I have to ask your pardon right away. Please excuse me. I have some upper respiratory viral illness which has both lowered the tone of my voice as well as given me this sort of strange New Jersey-ish accent with some southern pronunciation thrown in. Hopefully I'll get over it right away and get back to my usual melodious tones. We're going to talk a little bit about spinal taps, why they're performed, why they're not performed, and how they're performed, so that you will go forth and perform perfect spinal taps for the rest of your careers. Spinal taps date back to about 1889 when an English physician, Dr. Walter Winter, did the first access of the subarachnoid space. Now he did that with a cut down technique, and he wasn't looking to analyze the fluid but rather to lower the pressure of patients who are afflicted with tuberculous meningitis. A German physician, Dr. Heinrich Quincke, who's known for other eponyms in medication, performed the first needle access of the subarachnoid space, and then a Dr. Arthur Wentworth imported that technology to the United States. He was at Harvard University and published a treatise on the spinal fluid analysis in pediatric patients who had meningitis. And for his troubles, he was attacked by the Anti-Vivisection League for accessing children's spinal fluid, and as a result of that, never got his title over at the up-and-coming prestigious institution of Johns Hopkins. So, when you're going to perform a spinal tap on patient, it's a good idea to establish your rapport with them so that you can obtain an informed consent. Concept here is you need to give the patient sufficient amounts of information such that a reasonable person could make an intelligent decision regarding whether they want to proceed with that procedure. So you need to explain the mechanics of the procedure, why you're doing it, what information you hope to gain by the accomplishment of the procedure, what the risks of the procedure might be, and of course, what the risks of not performing the procedure would be. The most common indication for a spinal tap is to obtain the fluid, the CSF, to see if there is presence of any infection. Of course, tumor cells can be detected as well, and more specialized tests can look for oligoclonal bands, for example, for multiple sclerosis, or your protein level for suspected Guillain-Barré syndrome. Spinal taps can also be therapeutic in both cases of known intracranial hypertension, so that the CSF pressure, intracranial pressure, can be reduced, as well as the installation of medication at times for patients with carcinomatous meningitis. The most common contraindication to doing a spinal tap would be the consideration that the lowering of the subarachnoid pressure in the lumbar region could cause a pressure differential and may precipitate a herniation syndrome. So that in general, we always perform a brain imaging procedure before we do a spinal tap. If for some crazy reason that may not be possible, in that case it becomes absolutely mandatory to perform a very careful fundoscopic evaluation to rule out the presence of papilledema. Relative contraindications to spinal tap include coagulopathies, either elevated INR or lowered platelet count, less than 50,000, and in the minds of radiologists, the presence of antiplatelet medications, including aspirin, Plavix, Agrinox, makes them uncomfortable to do a spinal tap despite the absence of any real supporting literature data for that position. The most common complication of a spinal tap is the development of a post-spinal puncture headache, which is an indication that the dural tear from the needle has probably induced a small leakage of CSF, and as a result of that leakage, there is lowered intracranial pressure. The manifestations of that would be that when the patient goes from lying to either sitting or standing, there is some traction placed on the dura, which is very rich in pain nerve endings, and that very positional sensitivity to developing pain in the occipital area or the neck is an indication that there's lowered intracranial pressure as a result of the spinal tap. Other potential complications, like any procedures, would include infections or bleeding, particularly if you didn't follow the above guidelines regarding coagulopathies. Of course, patients can get a sensory sensation going down the nerve roots, and so as you place the needle, some patients may feel some shocking or paresthesias down the lumbosacral roots. Those are not usually injuries to the nerves, so they're transient. And again, the herniation, I would say that would be a more severe category of a complication, but thankfully I've never seen it. Hope never to see it, actually. So that's why we do it. Those are the potential events that could happen if we do it. Now, how do we do it? Well, it's a good idea to start with a lumbar puncture tray, since it's all been prepared for you. Unfortunately, this picture has not reproduced well, but you've got your tubes, your drapes, gauze, and sponges. This slide is a little inaccurate in that it says it has everything you need except for your gloves. Well, it actually doesn't have the betadine either, so you'll need gloves and betadine. And as you get ready, you're going to want to collect yourself, and you want to go down a list. You want to verify that you're performing the procedure on the correct patient. You want to also make sure that there's a written consent on the chart, and that you've gone through that entire list of contraindications and find none. This is one of the situations where doing a sort of pilot before flight checklists to make sure that everything is in order is a good technique. Now, where do you place the needle? Well, you want to go between the third and fourth lumbar vertebrae, or the L4-5 space. You determine that by your anatomical landmarks being the superior iliac crests, drawing a perpendicular line, and where it intersects with the midline, which is usually readily determinable by the spinous processes. So, you get your spinal tray, you open up the spinal tray, and then from that point on, strictly sterile technique is used. Just like any other medical procedure, it's performed pretty much in the same way that a thoracentesis will be, or a paracentesis. So you wash your hands, put your gloves on in the usual sterile technique. handle the spinal tray so that you access the inside sterile portions. You set your tubes up 1 through 4 in order so that you can grab for them when the spinal fluid is flowing and you don't have to fumble around. Before you do the spinal tap, you also arrange your 3-way stopcock and your manometer so that, again, when you remove the stylet, you can immediately attach the manometer to measure the opening pressure. So you get that ready, and you also get the anesthetic ready. So you fill up your 3 cc syringe with the local anesthetic. Then when all of that is accomplished and the betadine is poured into the tray, you get your sponges wet. The patient is positioned in the left or right lateral decubitus position with their knees flexed and head bent downward as much as possible so as to maximally open up your spinous interspaces. Now, it is possible to do spinal taps with the patient in the sitting position, and some clinicians, myself included, find that it's actually easier to have a successful spinal tap with the patient in that position. The caveat being that you don't get an accurate opening pressure if the patient stays in that position. So if you need to get an opening pressure, but you have to have the patient sitting up in order to place the needle correctly, then it would require that the patient be laid down while the needle is actually in position. So with the patient in position, you're going to prep the skin with the antiseptic solution by placing the sponge over the area where you're going to introduce the needle and use concentric enlarging circles. You apply your drapes, and after those are applied, you obtain your anatomical landmarks so that you feel for the iliac crests, and you can put an indentation in the skin at the interspace where you want to place your needle. Knowing where you're going to put the needle, you first do your local anesthetic. I usually only put in a small amount of lidocaine subcutaneously, thinking that I'm probably going to cause as much or more pain by giving more anesthetic as I will after the subcutaneous and cutaneous area is anesthetized. Now, before you give the little local anesthetic, you have to tell the patient with the euphemistic little poke warning, or you could actually be honest and say it's going to hurt like hell. We'll leave that up to you. The needle is a 22 gauge needle, and when it's introduced, the stylet must be in place. And again, it's inserted so that the needle is perpendicular to the dural fibers so as to hopefully reduce the risk of a post-LP headache. So you put the needle in. Let's see here. And you put it into the midline, angling it upwards about 30 degrees or so, or towards the location of the umbilicus. And you just keep advancing it. If you hit a bone, that will be pretty obvious. You won't be able to advance it any further. And if you advance it and then it suddenly gives away and there's little to no resistance, that is the so-called pop sensation when you know that you're in the subarachnoid space, which you get a feel for pretty readily after you've done the first 6,000 or 7,000 spinal taps. Once you think you're in the right position, you remove the stylet to determine whether there's spontaneous flow of CSF. You'll see dripping. Obviously, never ever attach a syringe to aspirate and see whether there's spinal fluid. If you see a drip, then you know you're in the right space. You attach your already prepared manometer so as to measure the pressure. In order to do so most accurately, you need to have the patient stretch their legs out so as to completely relax their abdominal muscles, since if there is any contraction of the abdominal muscles and raising of intra-abdominal pressure, that would be transmitted to your manometer and won't be an accurate reading. So you want to see that the patient is as completely relaxed as possible with their legs extended, and in fact see that there is variation of the CSF column with respirations. After that's been measured, you turn the three-way stopcock to allow the fluid that's in the manometer to go into the first tube, and then you put the manometer so that you put the stopcock so that the manometer itself is closed off, and so there is direct flow of fluid from the needle through the stopcock to the next tubes. You should be able to tell fairly readily whether you've had a traumatic spinal tap, in that you'll see either red or blood-tinged fluid. If it's frankly red fluid, then you probably did a venous cannulation and probably don't want to use that as spinal fluid. If it's pink, that's when you want to see if it clears and obtain fluid in both the first and fourth tubes to compare and see whether there's clearing of the blood as an indicator that you in fact had a mildly traumatic tap. Spinal fluid can also be cloudy, which is usually an indication of an infection, or even yellowish if there is any jaundice or raised protein in the fluid. You can take the fluid, hold it up against a white printed piece of paper and see if the black print is readily visible, usually an indication that it's entirely clear CSF. The usual standard orders for spinal fluid include tube number 1, cell count with differential; tube number 2, glucose and protein; number 3, get a gram stain and culture and sensitivity; and number 4, if necessary, cell count. If not necessary, it's always a good idea to instruct the lab, or actually request the lab, to save that 4th tube for potential studies down the road as they become necessary or indicated. Again, these are the ways that we insert the needle. Would be interesting to get a hold of these Sprott needles, because you see they don't have the opening at the very tip, so that this non-opened end can hopefully separate the dural fibers and cause less of a trauma, so that it would also reduce the incidence of a post-LP headache. It's a good idea to get the spinal fluid to the lab as soon as possible, because otherwise there could be lysis of cells and an inaccurate counting, or the glucose levels could go down. Any number of changes can take place if there's an excessive amount of time which is introduced from the time that the fluid is collected to when the lab begins analysis. And so if you can take it down yourself, the patient would benefit. After you've collected all the fluid, you want to replace the stylus in a sterile fashion, and only then remove the needle. If you were to remove the needle without the presence of the stylus, it could create some sort of suction effect, and again, impair the ability of the dural fibers to go back into place. After you remove the needle, you put pressure over the site for a few seconds, and then it's always good to put a Band-Aid on the area so that you know you were there, sort of your signature of a successful spinal tap. Congratulations. And so knowing all of these factors, you can go forth again and do perfect spinal taps. Some situations which may pose some challenges if there is a particularly gravitationally challenged patient, you may actually need a longer needle in order to arrive at the interspace. Sometimes patients move when it's inopportune, and so they will require some sedation. And sometimes it's difficult to get them into the optimal position, but you will deal with those as they come. So I have every confidence that everyone will go out and carry on in the fine tradition introduced by Dr. Quinky Low those many years ago. Thank you for listening. Bye-bye.